Hello, everybody. Welcome to Ophthalmology Mastery Clinical Skills for MBBS students. So, in this video, we'll learn about examination of a case of pseudophakia. So, this is also a common case that can be kept for your exams. How will you examine? What is the history that you would take? And what are the common questions asked in this case is what we'll look into in this video. So history usually you is obviously a patient who has undergone cataract surgery. So your history, you might think nothing is relevant, but you have to say patient has come for a regular eye examination, or if a patient has difficulty in vision, which they might have, like they've undergone surgery 1 year back and now they present with diminution of vision, or they might say their distant vision is fine but their near vision is reduced. So you have to give that history and present it. Patient presents with difficulty in near vision since 6 months. So HOPI, your history of presenting illness will be patient underwent cataract surgery for gradually progressive loss of vision few days back or few months back, and then now presents with blurred vision for distant or near vision. Okay. Some patients, even after cataract, they can have a difficulty in distant vision, though we aim to correct it for distant vision. Some patients, if it is a monofocal IOL, they will have difficulty in near vision. So if it is there, you will have to present it. Negative history of any glare, you have to ask no history of glare. You can also ask no history of redness, watering, which will rule out any complications of cataract surgery. Ophthalmic history, you will have to present patient underwent cataract surgery this many days or months ago. Patient had an if it was a normal case, patient had an uneventful surgery. His or her vision improved after cataract surgery and used drops for a month after surgery. And you might as well say patient was prescribed glasses at the end of 1 month. If not, not prescribed. Okay. Or sometimes uh, the history might be such that the patient might say patient had good vision after surgery, but then after a few months it reduced. Okay, so it might be a secondary complication after cataract surgery, or patient might say there was a trauma and after that vision reduced. So whatever is the history, you have to ask and present it. So after that, any examination will be similar to any case of the case. So first will be your visual acuity. You will check the distant visual acuity. If it is normal, you will write normal. If it is not 6.6, you will do the pinhole test and check if it improves to 6.6 on this Snellen's visual acuity. You will also do the near visual acuity test and record whether the near vision is N6 or N8, whatever is the near vision. Okay. If vision is not 6, reason for poor vision will be asked. Okay, so you're telling that the patient has undergone cataract surgery and you're presenting that the patient has 636 vision or 612 vision. The next question obviously will be, why is the vision less? Okay, so if you have done pinhole and you see that the vision improves to 6.6, then your answer is very obvious. You will say it is because of refractive error. Though the aim is to correct to make the patient emetropic after cataract surgery, the patient might still have some refractive error. So if it improves on pinhole, you will say it is refractive error. If the vision does not improve, I mean if the vision is 6.6 but near vision is reduced, then you will say that probably monofocal lens was used and that's why patient requires glasses for near. That would be your question. That would be your answer. Right. Now, if the vision is not 6.6, then again a reason will be asked, right? So what it could be, what is the refractive error that it could be? It could be a consecutive myopia where you overcorrected, a higher power lens is implanted. It could be a consecutive hypermetropia following surgery. So it's not, patient has not attained emetropia because of undercorrection. If the patient had good vision after surgery, and says but gives you a history very typical, has noticed blurring after a few months or years after surgery, then you will be asked what is the cause. So usually it is delayed complications of cataract surgery, which is after cataract, otherwise called as a posterior capsular opacification or cystoid macular edema. These are the most common causes for delayed onset of diminution of vision after cataract surgery. So here the vision will not improve on pinhole test. Please remember that. If it was a refractive error, usually patient noticed from the beginning, even immediately after cataract surgery, and they were prescribed glasses. Okay, but after cataract or cystoid macular edema, probably the vision was good after for some time, and after that it reduced. So you have to remember that this could be, if it does not improve on pinhole, it probably is because of either a posterior capsular opacity or some macular edema. Right. Next, you will examination. These are things that are important. You have to present all the findings like lid, lacrimal apparatus, everything, but you have to specifically mention this. In conjunctiva, you will look for the scar, whether it's superior or superior temporal. If it was a small incision cataract surgery, it will be a superior or superior temporal scar or a temporal scar. If it was a conventional ECC, it's probably a limbal scar. You will say that there I see a limbal scar, right? If no conjunctival scar is visible, then probably it is a phacoemulsification surgery and a corneal incision was put. That's why you see the conjunctiva is normal. Okay, sometimes you think, I mean, the patient might say that he didn't undergo a laser surgery or phacoemulsification, and you know it is a um, um SICS, but then you're not seeing a scar, probably because it's been many years, and you might not be able to identify it on torchlight. So you can say that I'm not able to appreciate on torchlight, but a slit lamp examination would be needed to identify the site of incision. So that would be your safe bet. Okay, so for small incision cataract surgery, we put scleral incision, which is around 1.5 to 2 millimeter behind the limbus. So you have to know. For conventional ECC, we put a limbal incision, so there'll be a limbal scar. Sclera, also the same thing. You will see a scleral scar with a superior or superior temporal. You have to look for it. Whenever a patient tells you that he has undergone cataract surgery and you're seeing a pseudophakic lens in the eye, pseudophakia in the eye, then you have to look for the scar. Okay, where is the incision, whether it's a scleral scar or a corneal scar, and what is the site of the incision. Then you will look at the cornea, whether it's normal, okay, or if there is any complication. And then you look at the anterior chamber. Anterior chamber depth is usually normal. It might be irregular if the lens is subluxate or displaced. Anterior chamber, sometimes content you have to examine if there is an IOL. There can be an anterior chamber intraocular lens like this one, right? So you have to note that, you have to mention that there is a shimmering light reflex present, or I see a IOL in the anterior chamber. Okay, then or iris, you can see iris, sometimes you can see iris atrophic patches. If they're there, you will present it. If not, you will say it is normal. Then pupil, it might be normal, sometimes it is peaked, or ovals, like this case it is peaked, right? Or in case of iris claw lens, it can be oval, and you will see a shimmering light reflex. You tilt the torch from one side to another, you'll see that shimmering light reflex in the pupillary area. That is indicative of an artificial intraocular lens. Right. So finally, after examining the whole eye, you will present the diagnosis as right or left eye pseudophakia with a posterior chamber intraocular lens. Or if you saw an anterior chamber intraocular lens, you will present it as anterior chamber intraocular lens. Any lens in front of the iris anterior chamber, behind the iris posterior chamber intraocular lens. So what is the management? So in this case, if you present it as pseudophakia, you will definitely be asked what is the management. If there was improve, if the vision was not 6/6, but after on pinhole it improved to pinhole, you will say I would want to do diffraction correction, right? If no improvement on pinhole, you saw that the vision was 6/12, 6/18, 6/24 or 6/12, but it was not improving on pinhole, you will say I would want to do a slit lamp evaluation and do a fundoscopy to rule out any what is the reason for reduced vision, and why it is not improving on pinhole, right? Now the common questions asked are types of intraocular lenses. So it can be based on position. It can be anterior chamber intraocular lens, which is placed in front of the iris in the anterior chamber. Anterior chamber is bound with the cornea in front and the iris in behind. Or it can be iris fixated IOL, where the lens is fixated to the iris, iris retrofixed IOLs, or it can be a sulcus fixated or scleral fixated IOLs where the lens is sutured to the ciliary sulcus. Okay. Or it can be a posterior chamber intraocular lens where it is placed in the lens capsule or capsular bag. Based on the material, it can be a rigid lens or foldable lens. Rigid is usually made up of PMMA. Foldable lenses are made up of acrylic, hydroxyethyl methacrylate, polymer, or silicon. Based on the focus, it can be unifocal where only one distance vision is corrected, multifocal where both distant and near vision is corrected, or extended depth of focus where the intermediate vision is corrected. Right? So you can the types of intraocular lenses is a very common question. Then what are the IOL related complications? It can be IOL displacement. Okay, these are late complications, sunset syndrome where the IOL, or early complications also IOL sinks down, sunset syndrome, or a sunrise syndrome where you see that the IOL is displaced upwards. Or sometimes we see something called as windshield wiper syndrome where the IOL keeps moving from one position to another because it's a smaller IOL, probably it's a smaller IOL, IOL diameter for that particular eye. Late complications again could be an after cataract or a posterior subcapsular opacification. What are the types of posterior subcapsular opacification or after cataract? It's the opacification of the posterior capsule which is left behind. There are three types: Elschnick's pearls, which are uh, pearl-like opacities in the posterior capsule. It can be a sommering ring where there's a ring in the periphery of the posterior capsule, or dense fibrotic capsule opacity. Okay, the treatment for any of these sommering ring usually nothing is required, but Elschnick pearls and dense fibrotic, if it is affecting the vision, then we do something called as NDR capsulotomy. Okay, these are the most commonly asked questions. The other question might be how do you calculate the IOL power? That would be an SRK formula. So you need to know that. So in conclusion, history you will say when the cataract surgery was, what did the patient come with. If they have no complaints, you will say came for a regular eye examination. Okay, or if they came with reduced near vision or reduced distant vision, you will mention that. You will tell the details about the cataract surgery, whether it was eventful, uneventful, how long did they use the drops, then did the vision improve after cataract surgery. You will check the visual acuity, you will comment about the distant vision and the pinhole improvement, near vision too. Then on examination, the conjunctival or the scleral scar and the anterior chamber depth you will mention, and the pupil color of the pupil is black pupil. Please don't say jet black pupil, it is black pupil with a shimmering light reflex, very important. And you will mention pseudophakia with a posterior chamber intraocular lens or in anterior chamber intraocular lens. The most common questions are the types of IOL and IOL related complications which you'll have to know. Thank you very much.